Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. In the era of technology and investigations, clinical examination is being forgotten. Especially in the respiratory system, a proper examination is replaced by CT scans, MRI, ABG, etc. But still, clinical examination is relevant and it is a cost-effective way to manage patients. So today I'll be discussing on auscultation of lungs in connection with the respiratory system, and today's topic is breath sounds. How will you auscultate a patient? Before auscultation, you should see that the patient is breathing to your satisfaction. It should be with mouth open and little deep inspiration. And see that the patient is not holding the breath. That is what I told you. The patient should be breathing to your satisfaction before auscultating. Don't close your eyes and auscultate because we have to identify inspiration and expiration by looking at the chest movements. In CVS, we go for the systole and diastole. Here, we have to identify whether the sounds are in inspiration or expiration. Second thing, when you are auscultating the breath sounds, what you are looking for is one is what is the inspiration like, there is intensity, whether there is a pause between inspiration and expiration. Third, what is the duration of expiration? These are the points that we will be looking for, and we'll be comparing the corresponding areas on equal side in a zigzag manner. That these are the basic things we look for. So now we'll be looking at the auscultation with detail. I have already told the patient will be breathing to your satisfaction before auscultating. And usually use the diaphragm, and it should be moved in such a way, the corresponding areas, and then you go in a zigzag way, then down. So this should be the way you will be auscultating. Now we go into what is the generation of breath sounds. The normal breath sounds, which when heard over the chest wall, usually use the diaphragm, the sounds are called vesicular. The vesiculars, the term is a misnomer because it gives a feeling that the sounds are produced in the alveoli. Wrong. Breath sounds are actually produced in the airways, and the lungs filter the high frequency sounds, and that is how you get the vesicular breath sound. So the vesicular sounds are actually modification of the breath sounds that are produced inside the airways. So the breath sounds intensity depends upon, one is the turbulence of the airflow, second is the diameter of the airway, and third is the interface, that is the chest wall, pleura, that is interfering with the transmission of the breath sounds. Hope this point is clear. The recap is breath sounds are produced in the airways, filtered by the alveoli, and when you auscultate over the chest wall, it gets what is called the vesicular characteristics. Now we look into what are the features of a bronchial sound first, because breath sounds produced are actually of bronchial nature because it is produced in the bronchi. You take your stethoscope and auscultate over your trachea. The tracheal sound is imitator of the bronchial sound, except that the sound is louder in intensity. So when you auscultate over the chest wall, what you get, the inspiratory sound is in loud. It is a high pitch sound and the frequency is around 600 to 1000 hertz. So that is why it is a high frequency sound. and it has got a high intensity also. There is a definite pause between inspiration and expiration. That is what sound you will be looking for, and the expiratory sound is also loud, and it will be heard equal to or even greater than that of the inspiratory sound. When you auscultate over the periphery, you will be getting the breath sound like this. That is the vesicular sound. That is a louder in the inspiratory sound is fairly intense, aspirating in quality maybe. And there is a no pause between inspiration and expiration, and the expiratory sound is heard only in the initial part of. I will draw it here once again. So this is the inspiration. There is no pause between inspiration and expiration, and the expiratory sound is faint and is heard only during the initial 1/3 of the expiration. So in normally inspiration, expiration, if you compare, expiration is longer, but the expiratory sound is shorter. It is heard only in the initial part, and in some people it may be even inaudible. So these are the difference between the vesicular sound and the bronchial sound. In bronchial sound, it is a loud, high frequency sound. Here it is a lower frequency sound. It is around 100 to 400 hertz. The higher frequencies are filtered off. So we are getting by the lungs, and we are getting only little more lower frequency sound in vesicular. There is no pause between inspiration and expiration, and expiratory sound is faint and is heard only during the shorter period. So these are the differences between vesicular and bronchial breath sound, and hope you understood the major differences between inspiration and expiration. Now we go to the textbook description of the vesicular sound. As per Hutchison, vesicular breath sounds are low-pitched, rustling in character, heard normally over the peripheral lung fields. Because near the central region, the trachea and other airways are there, and the sound may be little more like a bronchial. As per MacLeod, the breath sounds heard over healthy lungs is vesicular, inspiratory in character, and barely audible in expiration. And there is no pause between the two phases. And as per Harrison, vesicular breathing is a sign of normally aerated lungs. Any deviation should prompt assessments for underlying consolidation, effusion, or collapse. So, hope you understood the major things in about the vesicular breath sounds and bronchial breath sound. Now we look into when will you get this bronchial breathing. So we have already said that this is the trachea divides into bronchi, they divide, and finally at you get the alveoli. Whenever the alveoli is abnormal and the airways are patent, you get the bronchial breath sound. So the number one point to be remembered is bronchial breath sounds are heard only if the airway is patent. So that is one thing. That is only then only in the airway you are getting the turbulent flow, and that is why you are getting the bronchial sounds. So airway should be patent. Second, there is an interface. The sound should be transmitted across. So one of the condition that you commonly come across is consolidation. That is in pneumonia. What is happening? The alveoli gets filled with fluid. So what happens? It is solidified. But the airways are patent. So what happens? The solids are a better conductor compared to the air. So what you will get that directly the bronchial sounds are audible over the chest wall. That is why in consolidation you get a bronchial breath sound. So another classical condition is consolidation. Second is about there is fibrosis. The lungs are fibrosed. What will happen? Again, you can get a And airways may be pulled closer to the chest wall and you may get a bronchial sound. So you can get in fibrosis. Another important condition is the cavity, especially a superficial cavity. That the cavity is there, that can also produce a breath sound. And the frequency, depending upon the frequency, bronchial breath sounds are divided into the tubular, cavernous, and amphoric. About this, I have already done a video. Those who are interested can go and look into that and hear the video. So the point to be remembered is bronchial breath sounds are heard when the airways are patent, but the lung is solidified and the sound is conducted. Sometimes so we have already said the fluid is a good conductor. So why in pleural effusion you are not getting? In pleural effusion, what is happening? There is a collapse of the underlying lungs, and the sounds are not transmitted. So in a pleural effusion, the breath sounds are diminished. The reason is it is not because fluid is not a good conductor, it is because the underlying lung is collapsed. Hope this point is clear. So the breath sounds can be, we have already mentioned, the breath sounds can be one, it is a bronchial breath sound. Second is the vesicular sound can be decreased in intensity. Anything that interferes with the transmission of the sounds can be. So what are the conditions where you can suppose you think the patient has got an emphysema. In emphysema, what happens? The alveolus is expanded and the conduction of the sound is decreased. So in emphysematous patient, the sound may be decreased. Suppose there is a pneumothorax here. The air is not a good conductor, so in pneumothorax, the breath sounds will be decreased. Pleural effusion, it is decreased. In emphysema, it is decreased. So these are the common conditions where you get, and so of course in collapse also, collapse of the lungs. If the airways are not patent, you get the sounds will be decreased. We have said about the bronchial breath sounds, a typical example, we have said the patency, the airways are patent and the sounds are conducted. Rarely, in a case of pleural effusion, above the level of pleural effusion, you may get a bronchial breath sound. That is another thing you should keep in mind. Then how will you differentiate the consolidation from collapse? So in consolidation, the term itself means it is lungs are solidified. So there is no tracheal shift. Then secondly, there will be symptoms of infection. Whereas in collapse, there is volume loss. So tracheal shift will be there, movement will be decreased, all other findings of a volume loss will be there. But again, it can be confusing sometimes because along with the collapse, there can be consolidation. Also, there are some names for the collapse. Consolidation or a tumor may be the lesion for the reason for the collapse. That also should be kept in mind. So today we have discussed about the generation of the bronchial sound and what are the characteristics of sound and how will you look for, and some of the common or typical examples of development of bronchial sound. Stay tuned for further videos. Thank you.